would like to thank the Abbott for inviting me to attend this interesting symposium. These are my conflict of interest. So we know that technology promoted true revolution in diabetes care. In fact, there are convincing data presenting for the SWEET project that the use of CGM is able to reduce the AIC. Also, data from the type 1 exchange experience are showing the AIC is reducing subjects who are using CGM. And more recently, have been published other data that are demonstrated that independent from the fact that patients are treated by MID or a pump, the use of CGM is able to increase the time in range, to reduce the time above range, and to reduce also the time below range. Therefore, the blood glucose control of children and adolescents using glucose sensor and pumps is better than that of those that doesn't use them. But there are three emerging trends in children and adolescents with type 1 diabetes, in spite of the use of technology, hinder the process of improvement. The unsatisfactory blood glucose control in specific ages, especially adolescents, the still high prevalence of DKA after diabetes onset, and the increasing prevalence of overweight and obesity. There are convincing data published by the Search for Diabetes in Youth study, which demonstrated that adolescence is really a very bad period, because in that age you have a very high increase of A1C, but there are also other data published from the type 1 diabetes exchange clinical registry, who have demonstrated that in two different cohorts recruited, the first in 2010 and the second one in 2016, in which the introduction of technology was more present in the clinical practice, you can see that around adolescence, you have a very high increase of AB1C, and also recently, this still increased in spite of the use of technology. Therefore, this is a very dangerous age. In fact, also here are data published in UK, and you can see that the increase of A1C in both male and females is at the peak is reached at the age of 18. So around adolescence, you have very high level of high A1C, but this is also associated with a higher admission for DKA by age and sex. So you can see that females have a higher risk to be admitted in the hospital for DKA, also males, but around that age. The third factor is overweight and obesity. We know now that this is the data published from the SWEET registry, and you can see that the overweight and obese prevalence around the world was roughly 32%, so it's very high. And females have a higher prevalence than males. And interestingly, there is other data published in Sweden who are demonstrated that the prevalence of high BMI levels of overweight and obesity is higher in young females with type 1 diabetes in respect to the general population. Therefore, if we want to summarize the most important risk factor for DKA, we can say that age plays a role. We say adolescents. Sex plays a role, females more than males, and poor diabetic control, high A1C level. Also, there is a factor, is a prior episode of DKA. Of course, there are other factors that can play a role in promoting DKA, occurrence of DKA in children with type 1 diabetes. Then there are some precipitating factors. The most important, absolutely, of them is the mistakes in diabetes management, and the second one is infection. We know that 6 days are a dangerous situation for children. There are some potential advantages of using a continuous ketone monitoring system. The first one is to reduce the occurrence of DKA. The second, to increase TIR and to reduce TAR. Then it's also a tool for education and safety for optimizing and self-optimizing insulin therapy in subjects treated by MDI, pump, or ADI systems. And Yes, in this study has been demonstrated a better performance in blood glucose control than by ADA than other insulin delivery systems. In fact, the conclusions of this study are saying that ADA systems are more effective than conventional insulin therapy for children and adolescents with type 1 diabetes in outpatient settings. The favorable effect is consistent both in the short and in the long term. And ISPA, the clinical guidelines proposed in 2024, suggested that IAD systems are strongly recommended for youth with diabetes in order to improve time in range by minimizing hypo and hyperglycemia, person-reported outcomes, and reduce burden of care, especially in the overnight period. Therefore, we can say that if integrated in IAD system, CKM could offer useful information to improve the insulin dosing algorithm and lead to better outcome, especially in the event of infusion set blockage. There are several scenarios where additional CKM data may enhance the value of using IAD system. First of all, we have to say the failure of insulin delivery by the IAD system, but also the inadequate bolus dosing, recurrent DKA, the sick days, the stress exposure, the reduced carbohydrate intake and fasting, but also high-intensity exercise, SGLT2 inhibitor therapy, pregnancy, heavy alcohol intake, prolonged sedentary state, and social isolation. All these factors, may increase the chance to have. And if you look, I will present to you a clinical case. This is Julia, a 16-year-old girl. Type 1 diabetes onset of this girl occurred when she was 4 years old. She was on insulin pump from the onset of the disease, not an excellent glucose control. You will see the mean A1C was 7.9%, so it was not very good. And in 2024, we started the AD system, and the last download was TIR 49%, TIR 29%. So it was not doing very well. You can see AGP data here. I'll show you about this girl. This is one day, in this day, she missed at 6 o'clock p.m. bolus of insulin here. And you can see after that you have an increase of blood glucose. She has not taken care, she's interested in other stuff. And then also the pump, the system gave information about occlusion, the alarm, so she was aware of that. She take action, she changed the set, and then after that, it corrected bolus. And you see the glucose is going down. Then she checked blood ketones, it was very high. So this is, a situation that you can find in your clinic. So there was a long exposition to hyperglycemia, the development of blood ketones, and delay in the possible intervention. Now I have a question for you. What could be the advantage for this girl to have had CKM? Please choose one of these answers. To increase the efficiency in preventing hyperglycemia, to give additional information for suspecting catheter occlusion, to avoid hypoglycemia due to the hyperglycemia overcorrection, the algorithm, or all the answer above, please. Very good. Excellent.
Very good.
You are changing your vote. Yeah. So, thank you very much. So, I may conclude my talk saying that CKM should be integrated with CGM, contributing to reduce the incidence of DKA in children and adolescents with type 1 diabetes and preventing emergency department visit and hospitalization for DKA. New treatment algorithms based on ketone data obtained by CKM should be developed for AED system MDI as well. And then prospective studies necessary to assess the feasibility, acceptability, usability, efficacy, and safety of CKM in children and adolescents at risk for DKA. Thank you very much for your attention.